Welcome to the Radiology Vault, an open repository for radiology educational content designed for learners and medical professionals. Presented by the Michigan Medicine Department of Radiology.
Today we'll be discussing toxic disorders of the CNS with a focus on imaging patterns. My name is Shruti Mishra and I'm a neuroradiologist at University of Michigan. I have no relevant disclosures. The three imaging patterns we'll be discussing include acute toxic leukoencephalopathy, cytotoxic lesions of the corpus callosum, and posterior reversible encephalopathy syndrome. Acute toxic leukoencephalopathy is classically abrupt in onset with variable clinical features which can range from minor cognitive impairment up to severe neurologic dysfunction. Imaging findings associated with ATL are possibly reversible depending on the cause and are characterized by symmetric periventricular white matter T2 prolongation with sparing of the basal ganglia. Imaging and clinical correlative studies on ATL have found that the degree of imaging abnormality, particularly on DWI, correlates with the clinical severity of symptoms. In other words, presence of diffusion restriction and greater spatial extent of diffusion restriction is associated with greater clinical severity. The most common causes include chemotherapeutic agents such as methotrexate, immunosuppressive agents such as cyclosporin and tacrolimus, metronidazole, opioid or cocaine use, carbon monoxide poisoning, particularly in a subacute presentation, and certain metabolic derangements such as uremia. In this clinical example, this 55-year-old male with history of diffuse large B-cell lymphoma with CNS involvement presented with confusion after receiving intrathecal methotrexate. You can see on these two axial flare images that imaging findings include confluent T2 prolongation involving the periventricular and deep white matter with relative sparing of the basal ganglia. And you can see that these imaging findings were new from an MRI done 2 months prior. In this second clinical example here, a 57-year-old female with history of polysubstance abuse presented following heroin inhalation with altered mental status. And you can see, again, confluent changes on flare here involving the, symmetrically involving the periventricular and deep white matter. And on DWI and ADC, you can see that there is very mild relative diffusion restriction, particularly involving the areas of signal changes seen more posteriorly in the splenium of the corpus callosum and the parietal occipital white matter. Again, the degree of diffusion restriction has been linked to worse clinical outcomes. The second imaging pattern we'll discuss are cytotoxic lesions of the corpus callosum. Cytotoxic lesions of the corpus callosum are also referred to as clock lesions, are almost always diffusion restricting lesions involving with associated hyperintensity on T2 weighted images / flare. They almost always involve the splenium and are often isolated, involving the midline splenium location. In a minority of cases, involvement of the genu can also be seen, or involvement of the entire corpus callosum, which is more frequently seen in children. And in greater than 90% of cases, complete resolution is seen on the order of a few weeks. This clinical example is of a patient who is being started on an anti-epileptic medication. You can see a midline diffusion restricting lesion centered in the splenium of the corpus callosum with resolution on a 2-week follow-up exam. The most common causes to know in adults for clock lesions are drug-associated, vascular causes, specifically subarachnoid hemorrhage, and viral and secondary to viral illness. And of the drug-associated causes, the most common class of medications are anti-epileptic medications. But you can see in this list here that some of the other classes of medications that have already been discussed, such as chemotherapeutic agents, immunosuppressive agents, and metronidazole, have all been implicated. The most important cause to remember in children is by and large viral illness, which has been described in 75% or more of cases. And other etiologies, including bacterial infections, seizures, electrolyte disturbances, toxins, etc., are seen much less commonly in children. The third and last imaging pattern we'll discuss today is posterior reversible encephalopathy syndrome, or PRES. PRES is usually a reversible syndrome and can have a variable clinical presentation ranging from headache and vision loss to altered mental status and seizures. It's characterized by vasogenic edema, which you see on FLAIR, involving subcortical and cortical regions, most classically in a parieto-occipital pattern, but frontal and temporal lobe involvement is also seen very commonly, particularly in border zones. Less common areas of involvement include the cerebellum, thalamus, brainstem, and basal ganglia. On DWI, most areas of signal abnormality are classically iso-intense. On DWI, in other words, are T2 shine through, but less commonly you can see diffusion restriction, particularly, and when it's seen, it's in a punctate or focal gyriform pattern, but importantly, it's less extensive than the flare. So if you see extensive diffusion restriction in a gyriform pattern, you have to think about other etiologies other than PRES. Hemorrhagic PRES is seen uncommonly in less than 20% of cases and is characterized by imaging features of PRES with accompanying focal parenchymal or subarachnoid hemorrhage. Importantly, microhemorrhages are seen very commonly on SWI and does not necessarily mean that it's hemorrhagic PRES, as microhemorrhages can be seen in greater than 50% of cases. Post-contrast enhancement can be present. Again, when it's present, it's most commonly mild and can be gyriform, leptomeningeal, or cortical in distribution. And importantly, presence of post-contrast enhancement does not necessarily portend a worse clinical severity in this case. Risk factors for PRES include preeclampsia/eclampsia, post-transplantation, autoimmune illnesses, and medication-related, particularly immunosuppressant or chemotherapeutic agents. In this patient example, this is a 40-year-old female who was recently postpartum and presented with headache and vision changes. You can see multifocal areas of cortical and subcortical vasogenic edema on these FLAIR images involving bilateral frontal regions, kind of in the border zone locations, as well as in the parietal and occipital lobes. And there was accompanying focal cortical restricted diffusion in one of these areas, but the diffusion restriction was much less extensive than the areas of FLAIR signal changes. We will now have 3 comprehension questions to review what we just discussed. Feel free to think of the answer in your head before proceeding in the video. Question 1, recent use of which of the following medications is least likely to produce this imaging appearance? Here I'm showing you 2 axial FLAIR images showing confluent FLAIR signal changes in the periventricular and deep white matter. Of these answer choices, the medication which is least likely to produce this imaging appearance is vancomycin. Again, tacrolimus and cyclosporin are immunosuppressive agents. Methotrexate is a chemotherapeutic agent, and metronidazole is an antimicrobial which has been described to cause ATL. Which of the following etiologies is least likely to be the cause of the following imaging findings? In this case, I'm showing you a focal diffusion restricting lesion in the midline splenium of the corpus callosum, in other words, classic for a clock lesion. And of these answer choices, the least likely etiology is an arterial infarction. Remember, clock lesions that are due to a vascular etiology are most commonly related to subarachnoid hemorrhage. The splenium of the corpus callosum has a rich arterial supply, and therefore arterial infarction is an extremely uncommon cause for this imaging appearance. Finally, which of the following imaging findings is least consistent with PRES? Posterior predominant vasogenic edema, cortical signal changes on T2-weighted imaging, cortical or subcortical restricted diffusion, and microhemorrhages on susceptibility weighted images? The answer is all of the above can be seen in press. Thank you for your attention, and this is my email address. Feel free to reach out with any questions.